Hi, everyone. We're going to go ahead and get started. Welcome to our webinar on pelvic floor neuromonitoring. We're very excited. We have over 400 people, and perhaps even more importantly, we have over 41 countries represented. How exciting. A couple of housekeeping notes. If you're new to the Zoom platform the way I am, there is a top button called View Options that has a zoom ratio highlighted here. It will help you optimize your viewing settings, and I created a slide with top left, top right, bottom left, and bottom right. I'm gonna leave that there a second and let you select the optimal setting for your view. In the bottom panel, there's a couple of important notes. The chat window is there in case you have technical difficulties. We have someone standing by. Giorgio is there to help if you have any technical difficulties with the Zoom functions. We ask that you reserve the Q&A button at the bottom, highlighted here in red, specifically for questions related to the webinar content. We're excited about the question and answer session at the end. Anytime your questions arise, please just go ahead and enter them via this Q&A option. Our schedule includes 30 minutes for Dr. Jahangiri to present the neurophysiologist perspective, followed by 30 minutes for Ms. Overzet to present the technologist perspective. One thing we know from the scientific literature of neuromonitoring from around the world, the efficacy of the outcome highly correlates to the uniform teamwork between all the different the surgeon, the OR staff, the neurophysiologist, the technologist. We're very excited to have two of those very important functions represented here. Our presenters specifically asked for a short 30-minute session of their talk so that we could have a longer interactive question and answer session, which we're quite excited about. One note, we will conduct polling throughout the webinar, and we humbly ask, try as much as possible to select your answer within the 30-second window. That's going to help us stay on schedule. I will just briefly say that my friend Faisal Jahangiri, Dr. Jahangiri, I am safe to say he is the hardest working individual I know in our industry. He is relentless at maintaining an intense schedule of new study, new publications, new presentations, new educational material. And if you know him, you know that he's willing to speak with anyone in our industry. Over the 6 years that I've gotten to know Katie, I've found her to have an infectious passion for neuroscience, as evidenced by her bachelor and master in primary neuroscience. And she is well published, and we're excited to have her. She's a frequent educator, very good at what she does. I will say that I've been fortunate enough to seek out heavy peer-reviewed, well peer-reviewed literature, review articles, books from physicians, from neurophysiologists. There are two things that always present for me: pelvic floor innervation and even pelvic floor anatomy. That information is still being developed. My point, we still have a lot to learn. With that, I hand it off to my friend, Dr. Jahangiri.
Thank you, Brett, for the inviting for giving a talk here. And first thing I want to disclose that I am still learning. So this is as you said, this is a new field, and so I'm just going to share my screen. So this is a new field for all of us, and we have still a lot of different topics to explore: the anatomy, the physiology, the pathology, and how we can help the surgeons to minimize the deficit which can occur during the surgeries which involve these surgical procedures. So saying that, I don't have any conflict of interest to disclose at this point. So the learning outcome for this presentation, I'm trying to give a big over picture. It's very hard to have full-scale training in 30 minutes, but just to provoke the thought process and involve more people to getting being part of this new surgical area where we can help the surgeons, the patient, and the community. So intraoperative neurophysiological monitoring helps in better patient outcome by minimizing the risk related to the functional status of the nervous system during surgical procedures. So as we know, IOM alert to the surgical team during surgery can help them to identify the cause and take an immediate corrective actions. Learning about the advantage of IM during pelvic floor procedures. So those are the so the purpose of IM again just is to reduce the incidence of iatrogenic injury and any randomly induced neurological injury to patient during surgical procedures. IM consequently confer possible benefit at many levels, including improved patient care, reduce the time of temporary deficit. It reduces the revision procedures. It reduces rehabilitation and recovery time. It reduces the hospital stay and medical cost involved with that. It reduces the overall burden on the insurance. It also reduces the liability by protecting the patient as much as possible. So pelvic floor neuromonitoring, the structure of the autonomous nervous system are complex in the pelvis, and sometimes they're difficult to differentiate from each other. The IEM during pelvic floor surgeries can minimize the risk of nerve damage, and it can monitor the nerve function and can minimize consequential nerve damage and help in maintaining the quality of life of the patient post-operatively. Because these, as we're going to talk in next slides, bowel and bladder are the most common structure, and any deficit on those bowel function or bladder function can have a very significant effect on the patient quality of life. So neuromonitoring during pelvic surgeries can reduce the risk of incontinence. It also can reduce in sexual dysfunction. Pelvic neuromonitoring can help in the variety of surgical procedures in the pelvis. I'm going to talk. So there's a potential of injury. There are 5 regions of potential nerve injury that can be identified. You have superior hypogastric plexus. We have hypogastric plexus nerves. We have inferior hypogastric plexus and inferior neurovascular bundles to the rectum and urogenital organs and terminal pudendal nerve branches. So innovative techniques like pelvic floor neuromonitoring and important in laparoscopic surgery enable the surgeon to detect the complex neural network and verify these internal anal sphincter and urogenital functions. So various surgical procedure where we can do this type of monitoring includes neurosurgical procedure, quad equina tumors, tumor involving anything neuroconus, tether cord release procedure including myocele, meningocele, orthopedic surgery. So any orthopedic surgical procedure where sacral tumors involving those um, the sympathetic parasympathetic plexus at risk, and also lateral spine procedure where the nerves, pudendal nerves and lateral nerves, they are at risk. General surgeries and colorectal, especially colorectal tumor resections, gynecological procedures including hysterectomy, and urological procedure such as prostate surgery and prostate resections. So pelvic floor is a group of muscles and connective tissue in the pelvic area. These muscles support the organs in the pelvis like a sling. The organs in the area include bladder, vaginal cavity, the uterus in the female, and prostate in the man, and rectum, which is the area at the end of the large intestine. Bowel movements and bladder emptying are controlled by contracting and relaxing these muscles. The pelvic floor disorder is common condition that affect both men and women of all ages. 1 in 5 people will suffer from pelvic floor disorder during their lifetime. And 1/3 of all women and 50% of women over the age of 55 are currently affected by pelvic floor disorder. Researchers estimate almost 10% of these women will undergo surgery for urinary incontinence and conditions or pelvic organ prolapse during their lifetime. So looking at the anatomy of the pelvic floor, so So we have urinary bladder, and the bladder have a smooth muscle wall, and the trigone is the area where the bladder meets the ureter. Um, and we have internal urethral sphincter and external urethral sphincter. So the pudendal nerve is the main nerve supplying those areas. For controlling the urethral sphincter. It originates from S2, S3, S4, and very occasionally it also originates from S1 or uh, sometime. The pelvic nerves, um, we have sympathetic nervous system and parasympathetic nervous system. So I'm going to go more detail later, but the function of the parasympathetic nervous system is to control the bladder by contracting contracting the smooth muscle and relaxing the sphincter for urination. The sympathetic um, control the bladder relaxation. So when you're looking at the anatomy of the pelvic floor again, the lower urinary tract innervation and neurotransmitters. They are afferent and efferent fibers covering the hypogastric plexus, the pudendal nerves, and parasympathetic neurotransmitters. So the, the so you have the roots which are coming from thoracolumbar cord and sacral cord. The thoracolumbar cord roots come from T1 to L2, and for sacral root they come from S2 to S3. There are clinical consequences of abnormal urine storage and voiding after severe upper motor neuron or suprascalar spinal cord injury. So even those surgical procedure, they are not a pelvic floor procedure, but if there's a damage to the upper motor neurons, um, which is controlling these muscles, that can have a consequence of the bad outcome. So if in case of normal storage, an A fiber respond to gradual bladder distension, but in case of spinal cord injury, the overactive C fibers, afferent fibers fire spontaneously, and it result in neurogenic deterrence overactivity. So if you have a neurogenic patient has a neurogenic bladder, patient will have a urine leakage for rest of the life, decreased storage capacity, decreased compliance, and increased intravesicular pressure. So at the end, the recurrent urinary tract it results in a recurrent UTI infections, multi-drug use resistance. So patient will be on multiple antibiotics and they will develop the resistance. The upper urinary tract infection and deterioration can also occur because if the patient has lower UTI infection, it will spread to the upper UTI and can affect the kidneys as well. It will reduce the quality of life and the lifespan of the patient. So this is so we're just doing the first poll. So the most common types of pelvic floor disorders include pelvic organ prolapse, pelvic urinary incontinence, pelvic fecal incontinence, and pelvic floor. Before we decide and think about what we can monitor and what structure are at risk, so we go from the other side and we say what are the clinical consequences of the damage to these nervous structure. And most of the time, those are the common type of disorder that we see in the clinical patient in clinics. They come with a pelvic organ prolapse, single organ prolapse or multiple organ prolapse. They have urinary incontinence, or they have fecal incontinence, or they have pelvic floor. So the common modalities that can be used to minimize the damage, we can add pudendal nerve SSAP, we can add bulbocavernosus reflex or BCR. We can do motor evoked potential from external urinary sphincter and external anal sphincter muscle. We can do EMG from external urinary sphincter and external anal sphincter and internal anal sphincters. So those are the 4 modalities we can add to our normal routine monitoring. So it's always better to have all the studies. Again, there's no one study or one modality that can prevent the patient to the maximum extent. So in order to give the patient the maximum benefit, we need to have a multi-modality monitoring, because every modality has their pro and cons. So when we combine them, we get the maximum benefit. So cavernosus reflex. Bulbocavernosus reflex is a reflex in the pudendal nerve which cover the sensory roots which are going to the spinal cord from the patient from the patient in the patient, and the reflex coming back from the spinal cord to the anal sphincter muscle. So we are going to cover more on technical aspect, but so BCR is useful in determining the functional status of the pudendal sensory motor reflex and conus medullus during surgical procedures. So all the surgical procedure where the pudendal nerve is at risk, we can add BCR, and the BCR will give us the information or the reliability or functionality of the sensory root of the part of the pudendal nerve as well as the motor part. So we do by stimulating the dorsal surface of the penis in the male patient and inside the vulva on the female by stimulating that and recording from the anal sphincter bilaterally. So the typical recommended method of stimulation parameters is ISI of 3 to 3.1 hertz, which is 333 hertz. So, so ISI of 3 millisecond or 333 hertz, train count of 4 or 5 pulses. The duration of the pulse should be about 500 microsecond. The current you can range from 2 to 50 milliampere, and you can do a single train stimulation and double train stimulation. When you do the double train stimulation, so you have to make sure you increase the duration of the recording. So this is the waveform. So when you have a multiple train, there are 5 pulses, stimulating with 5 pulses and recording from the left and right anal sphincter, and the bipolar, and you get 2 different waveforms. One is R1 and one is R2. Those are early and late waveforms. So those are recorded, and you can do continuous stimulation along with other modalities. If you're looking at the stack of the BCR responses on the left BCR and right BCR, so the stimulation is in midline, so it's a unilateral stimulation, but in midline. So it's very difficult to stimulate the left and right side. It's not possible. So, but the recording, you can do left and right separately recording. So you can have a pair of electrode on the left sphincter and a pair of electrode on the right sphincter. So the second modality that can be uh, included in the pelvic floor mounting is pudendal nerve SSE. So doing the somatosensory evoke potential, but utilizing uh, pudendal nerve. So Hellman et al. Demonstrated that the amplitude of the pudendal SSP was maximal over sensory cortex at CPZ for both men and women, and the latency of waveform are similar to those obtained just as tibial, but a little bit more delayed. So the recording channel we use is CPZ to FPZ. You can add subcortical responses, but the subcortical responses are not as reliable, but it's always good to have subcortical responses in those two. But the cortical responses, the cortical responses look like a W special, and with the P40 down peak followed by N50 up peak and then P60 down peak. So we can do continuous stimulation along with the other SSP and record. So we have, when you're doing bulbocameral PCR responses, we are doing monitoring the reflex in the pelvic floor. But when we're doing pudendal nerve, we are monitoring the sensory root up to the somatosensory cortex. So the other modality we can include is motor evoke potential. So motor evoke potential as are performed as a regular stimulation and recording setup, but you can add external anal sphincter and external urinary sphincter. So now we can record from In the past, we were doing just the anal sphincter EMG motor evoked potential, but now we have capacity of recording external urinary sphincter during pelvic floor surgeries or surgeries where these structures are at risk. So this is the paper we published. So just giving you the summary for that. So we did multi-center studies in 5 different medical centers in 3 different countries, and we had 15 patients with 47% female and 53% male, and the average ranging from 8 months to 66 years old. And the type of surgical procedure we monitored were conus tumors, spinal cord tumors, tethered cord, and there's a one case where patient has spinal stenosis. So for this surgical procedure, so we had upper and lower SSCP, upper and lower MEP, spontaneous EMG from external anal sphincter and external urethral sphincter, and lower extremity muscles bilatery. A catheter was used which has attached urethral electrode on a Foley catheter for recording MEP from external urethral sphincter. Trainer for was used from the foot muscle, and the appropriate site of urethral catheter should be used per patient age. So we cannot have one electrode. So when you're doing the monitoring, or you know the patient age, so you have to make sure you have the appropriate size of the Foley catheter. And the typical Foley catheter are measured in French scale and FR, and each unit is roughly equivalent to 0.33 millimeter in diameter. So if you have an 18 franc catheter, that means the diameter is 6 millimeter. So every single unit is 0.33 millimeter. The urethral catheter, the size option, we have size 8 and 10 for the children, and the Foley catheters used for adults is 14, 16, and 18. They come in different sizes, and they are bipolar electrodes, so you can use except for the 8 franc, which is a monopolar probe, but 10, 12, 14, all the Foley catheters, embedded electrode, they are bipolar electrode. So recording the motor evoked potential from, and also for spontaneous EMG from the blood electrode. So when we place these electrode, they are in contact with the external urinary sphincter of the bladder, and the muscles for the male and female, they are at different location. So male is more distal, female is more proximal, but you can do direct recording. So if you look at the picture on the left side, it's a printed electrode, and on the right side, this is plug into the patient, and we have a bipolar electrode, and we can just plug into the amplifier box as anode and cathode. So in this image, you can think we're running continuously MEP, so you can see with the minimal patient movement. So when you're doing MEP, so it's very critical to make sure you're placing the electrode for stimulation at the cortex after measuring the head. And so with the minimum patient movement and have accurate parameters. So we have like every 30 seconds, so we are stimulating MEP from 30 seconds. But this is, we are comparing the left sphincter with the right sphincter and the urethral electrode MEP. So we have very good, robust, repeatable, and reliable MEP during this surgical procedure. In other patient, we have on the left side and the right side, so left MEP and right MEP, comparing left foot, left anal sphincter, and right foot to the external urethral MEP. So for result for this study we had 14 patients had a good motor responses. So the success rate for this one, out of 15 patients, we have 93% patient we have good MEP. Only one patient we were not able to record. TCP for anal sphincter was not recorded in one patient, and it was poor in 2 patients and reliable in 2 patients, and was not recording on 1 patient. The amplitude of MEP was much higher for the urethral electrode compared to anal sphincter in this study. So the next modality we are going to talk about is we can add to the surgical procedure is spontaneous EMG. So electromyography is the same electrode can be used for EMG, same EMG that we are using for motor evoked potential. And so again, it's a part of the multi-modality monitoring. So you can do trigger EMG and motor evoked potential from this same electrode. So we did a retrospective analysis of IM data from patient. We have 7 intradural tumors, 3 tethered cord release surgeries that use these electrodes, and we recorded in 2 different medical centers. The age of the patient, we have 5 male and 5 female, and the youngest patient we had was 8-month-old, and the oldest person was 67-year-old. So so there are different patients. So we are sorry. So for the 47, so different, we use different catheter size. So we just so we have conus tumors, laminectomy, and tethered cord patient. So the 8-month-old, we use 8 franc, which is size typically used for about 1-year-old or patient. So we use 8 franc for these patients. And then 6-year-old, 8-year-olds, we have 10 franc, and then we have 18 years old. So depending on the age of the patient and the sex of the patient, we use different size of the catheter electrode for regarding EMG. So when we are doing, so another interesting thing is when we are doing MEP and EMG, so beside recording and stimulation parameters, so it also very, very critical to know what type of electrode you are using for muscle recording. So again, this is another study published where we compared the success rate of 13 millimeter to the longer needle electrode. And on the right side, you can see this is one of the patient where uh, we took the X-ray after the surgery, and you can see the 50 millimeter electrode was close to the muscles near the femur compared to 37, 25, and other electrode. So this is one of the patient. So for the longer needle, you can put the tegaderm or put the tape on that, but they were very, very secure, and even without putting the electrode, but 13 millimeter was very small. So these are very important for the patient who have high BMI. So the patient very obese, and the diameter of the muscle is very, very deep in the adipose tissue. So you have to use the electrode, longer electrode, to record that. So in this patient, you can see we use 13, 18, but if, so it was no response in 13 and 18 millimeter, and we have very small response, about 150 microvolt in 25 and 37 millimeter electrode, we have about 700 microvolt response. It's a huge response. And if we have used only 13 millimeter, we had no response in this muscle. And this is the recording from our rectus femoris muscle for quadriceps. 100% success rate for the patients we did in our study. So these are the responses. So comparing the left foot muscle, left sphincter muscle, and the right side. So the blue area is the left anal sphincter response from the left side and the right side. So when you're doing modalities, so we have multi-modality again. So the next modality, I'm just going to go briefly, is the autonomic nervous system. So the autonomic nervous system is also known as visceral system because the autonomic nervous system supplies all the visceral organs of the body. So it's also known as visceral nervous system. So it is neuronal groups and fibers. They are connections that control the activity of visceral organs and the blood vessels and the gland. It is divided into sympathetic nervous system and parasympathetic system. So in another talk, we can go in much detail, but today just giving you a summary. So the sympathetic nervous system, both systems have preganglionic nuclei and the postganglionic nuclei. So the length of the pre of the first neuron is different. So both length of the neuron are different in sympathetic versus parasympathetic. So the preganglionic neurons for sympathetic are at level of thoracic 1 vertebra to L2 segments. They release norepinephrine and they act in bowel and bladder. And when they act beside the vessels and the gland, in bowel they cause smooth muscle relaxation, and bladder it causes detressor, which is another smooth muscle of the bladder wall relaxation. Activation of the parasympathetic nervous system, which originate from S2 and S4 segment, release acetylcholine, and it causes bowel and bladder contraction by acting on the same muscle. So the main difference between sympathetic nervous system activation and parasympathetic activation is relaxation versus contraction of ball and bladder muscle. Multimodality monitoring of autonomic nerves of pelvic with internal anal sphincter EMG and the urinary bladder manometry has been used in advanced nerve sparing surgeries to improve functional outcome. Koff et al. Also published that initial results suggest that IOM may result in lower rates of urinary and anorectal dysfunction and may predict male erectile dysfunction by monitoring. So monitoring of autonomic pelvic nerves can be performed during robotic-assisted low anterior rectal resection. So during the surgical procedures involving colorectal surgeries, bladder surgeries, prostate surgeries, having EMG, MEP, and bladder pressure monitoring can maximize the postoperative benefit. In other studies by Portner et al. Reported severe sexual dysfunction in 35% male after quad equina injury. So then monitoring these patients can help. A study by Possover to have a variety of genitourinary disorders in women undergoing radical pelvic surgery, and 30 in the study 30% risk of impotence in men with most favorable preoperative radical prostatectomy, and another study reported fecal incontinence and urinary sexual dysfunction after colorectal surgery. So the different type of surgeries involving these areas, they can have significant postoperative deficit, which range from as high as 30-35%. So again, going back to the pudendal nerve, it derives from the ventral lemma of S1, S2, S3, S2, S3, and S4 roots. Sometimes get the S1. It continues through the greater sciatic foramen and enters the lateral direction into the ischiorectal fossa. Its muscular branches innervate the external anal sphincter and the external urethral sphincter. So we can, if you put the electrode in those two sphincter, we can monitor those two. Also, the muscular branches of the muscular levator ani muscle, we can be monitored, is supplied by the pudendal nerve. So, if you're looking at the top bottom picture on autonomic nervous system, so yeah, the sympathetic fibers, they start from very high from the brain stem, and they come all down to the sacral area, and you have supplying rectum, bladder, and the prostate in the pelvic area. So the key factor for doing all of that is it reduces the risk of postoperative neurological deficit by providing consistent standard of care of patient, monitor the neural structure at risk during these type of surgical procedure, and the different modalities we discussed. So we can add pudendal SSCP, we can add bulbocavernosus reflex, we can add EMG, motor evoked potential, and bladder pressure monitoring for various type of surgery, not only just the neurosurgery, or also some type of spine surgery involving the sacral area, and also gynecological procedure, urological surgical procedure, and general surgical procedure. So if you're doing monitoring and having multi-modality defect, where we can give the surgeon an immediate feedback about different and give them. So there are different papers. So if you want to reach out to me, and I can send you the link for different surgical papers, which shows the benefit of monitoring in these surgical procedures. Thank you.
So we ask that you continue to submit your questions, and thank you to the people who are submitting questions. We are going to save those questions for our question and answer period at the end.
Hi guys, how are you doing today? All right, so I am going to go ahead and give you guys an overview also of the technical setup and recordings, and then go over some patient data of the modalities that Faisal just mentioned previously. So no conflicts of interest on my end. And just to give you guys a setup of exactly how we're going to go through everything, we'll first discuss the technical setups, do a quick pathway review, go over the anesthetic conditions, the unique supplies, the patient setup, show you guys the protocol and settings for recording and stimulation, and then some morphology and the components of the waveforms. And then if there's time, we'll also go through 2 case studies, one of which is an intramedullary spinal cord tumor resection, and then a pediatric tethered cord release. So 2 techniques that we employ, which you guys, if you're already doing intraoperative neurophysiological monitoring, you know there are 2 main things that we accomplish in the OR, both monitoring, which is going to encompass your somatosensory evoked potentials, motor evoked potentials, spontaneous EMG, and then the BCR to identify changes in the nervous system functioning, hopefully always prior to any irreversible damage. And then also mapping, where we're looking at triggered EMG or nerve conduction to identify neurological structure and physiological changes that might be occurring in the surgery to distinguish functional tissue from non-functional tissue. So the 3 main modalities we'll go over today: the reflex, the bulbocavernosus reflex, pudendal SSEPs, which are going to be a little bit different for stimulation of the dorsal nerve on males versus females. And then grouped together, we'll discuss motor evoked potentials, transcranial electrical motor evoked potentials, and electromyography from the external urethral sphincter. I won't go into too much detail about the anal sphincter as this one's pretty well covered, I think, at this point, but I will have some pictures and examples as well. So we'll start with the reflexes, the bulbocavernosus reflex, also known as the bulbospongiosus reflex, BSR, or pudendal anal reflex. And we have our first poll question. So do you guys feel comfortable explaining to someone what information a reflex response gives us intraoperatively? And we'll come back to that at the end of this section. I need to get this question out of my way. Okay, so let's just do a quick reflex review. Help you guys answer that question a little bit. So the function of any reflex is to maintain homeostasis in the body. And a reflex arc is the simplest nerve pathway in the body, and it involves the sensory and motor neuron at minimum. There are 2 types. We have somatic and autonomic or visceral. So the components of the bulbocavernosus reflex arc, first we have our sensory receptor and the neuron, which I'm going to group just because specifically for this, we are bypassing the sensory receptor since we are stimulating directly, but there's a response to the stimuli, and that sends an action potential and propagates that action potential to the central nervous system. And for the BCR specifically, that is the dorsal nerve of the clitoris or penis, and that propagates to the pudendal nerve. Once it reaches the conus, oh, there, I'm trying to find this, it will connect with an interneuron, and then that passes the signal off from the sensory to the motor neurons via synapses in the central nervous system. So specifically for the BCR, you have a group of pudendal motor neurons in the conus known as Onuf's nucleus, and that's located in the ventral gray near the distal tip of the conus medullaris. And that sends another signal back down the chain via the motor neuron to an effector muscle. And that causes a contraction. So traveling back down the S2 to 4 spinal cord segments, and we get a contraction of the bulbocavernosus or bulbospongiosus, which is highlighted in red in the pictures to the right on the female in the top picture and the male in the bottom picture. The reason why it's called the bulbocavernosus is because that's the muscle that contracts. However, the anal sphincter contracts as well, and is known as an anal wink, and so we are able to record from that a little bit more easily than from the bulbocavernosus itself. So anesthetic considerations, I think this was one of the questions on the last presentation. Anesthesia for bulbocavernosus reflex, since there is the motor pathway involved, we have to have a train of 4 of 4 of 4, and highly recommended to use a TIVA regimen with propofol and a narcotic induction if possible. Maintain an adequate map for the patient. And the contraindications really are gas. So it is an oligosynaptic pathway. There's multiple synapses. And so gas causes a significant attenuation or loss of the signal. And this is from a study in 1997 of Delitis. And they started the case with gas everything off, got a beautiful response, and then turned on isoflurane to 1.25% to see how it would affect the signal. And you can see a huge decrease in the size of the response. And then after the response had, it started decaying, they turned the gas back off. And it still took about 30 minutes later for the response to recover from the deterioration that had occurred from the gas. So ideally, you really do want to go with a TIVA regimen to be able to monitor these reliably in your surgeries. So the supplies that we use, recommended a 19 to 25 millimeter paired needle electrode for recording, and then a 7 to 13 millimeter paired needle electrodes or surface electrodes for stimulating. And I'll go into a little bit more detail about the difference between using a paired needle versus a surface electrode for these in a moment. And then really just the biggest no-no is to avoid insulated electrodes. So because the anatomy of the anal sphincter you want the entire needle to be collecting a recording rather than just like a small tip of it that could pierce through or might not be exactly in the area you want to record. So you want to have a really large surface area for recording. The patient setup for stimulation, we recommend the use of short bare needles. You can use surface electrodes, but we'll go into a little bit more detail, like I said, in a minute. There's a better chance of getting the early ipsilateral responses independently if you use needles as opposed to the surface electrodes. And for males, there are two options. You can do a unilateral stimulation by placing the cathode on the dorsum of the penis and then the anode at the distal penile shaft. Or you can do a bilateral recording. And again, kind of two options here for the bilateral stimulation. You can place the cathodes implanted on either side of the proximal infrapubic penis with the anode far lateral penile shaft. Or in 2017, Dr. Skinner did a really wonderful webinar where he described the use of needles placed at the shaft of the penis below the pubic bone with two cathodes in the center and two outside from them. And I'll show you guys how that setup looks and recording. So for unilateral stimulation, just placing it there on the dorsum for the dorsal nerve, your cathode and anode. And then for the bilateral stimulation, you can place the needles at the top with the anodes on the outside of your cathodes. So just the entire pathway from stimulation to recording, plugging into your anodes and cathodes. And just note from this picture, of course, the stimulation would occur on the dorsal side or in the picture that I showed previously with needles at the top of the shaft. Stimulating, and that travels up the nerve roots into the conus. We have the interneuron carrying that signal to Onuf's nucleus. That response travels back down and out and then causes the reflex in the anal sphincter, which we then record. So this is the complete pathway with the setup. So for females, just a little bit different, obviously, as the anatomy is different. So you can do a unilateral stimulation, placing the cathode on the proximal infrapubic clitoris, and then the anode on the labia majorum on either side. Or for a bilateral stimulation, you can actually place two cathodes at the clitoris, which is very small real estate, but still possible, and then one anode on each labia majorum. So this is what a bilateral stimulation setup would look like. So again, just kind of easier with the real estate to utilize a very small needle. Also, just able to secure them a little bit more easily is that the skin on that area can sometimes be difficult to place surface electrodes that will actually, that will stay in place. And then we'll go through the full patient setup. So you got your stimulator, your anode and cathode there on the labia majorum and the clitoris. Same exact thing, travels up the nerves. And we have the interneuron carrying the signal to Anos nucleus, travels back down, causes that contraction in the anal sphincter that we're able to record. So just a few notes on independent stimulation on each side. The cool thing about it is it does permit a higher possibility of monitoring the early ipsilateral responses independently on the left and the right. But just know that by reason of proximity, of course, of the dorsal nerves to each other on each side, as they course infrapubically, there is a very restricted ipsilateral stimulation to be obtained. So it's definitely uncommon and shouldn't be expected. So for your recordings, you'll use 19 to 25 millimeter non-insulated, as we discussed, needle electrodes placed through the glabrous non-keratinized skin of the anal verge. Dr. Skinner recommends a 22 millimeter depth for your electrodes. And so you can kind of see from these pictures just how centralized and how deep the muscle is. And so it's important to use a needle that's long enough. So if you're using like a 13 millimeter, there's a chance that you're missing some of the recording just by the lack of the needle not getting deep enough. It should pierce the subcutaneous component of the external anal sphincter, and that's the part that's highlighted in green in the pictures to the right. And then it's recommended to use 2 electrodes per hemisphincter, about 1 or so centimeters apart from each other. And the reason why we do take a bilateral recording, even though it's a funnel-shaped muscle that's relatively circular, it is still innervated separately on both the left and the right. So it's best to take a recording from both sides if you can manage that. So just a few technique tips from the setup end. Apply tape liberally to secure. In one report out of 100 cases that BCR was performed, 6 of them had an unobtainable BCR, and they actually found that 4 out of those 6, the reason why they were unattainable was because the electrodes had become dislodged. And again, that kind of feeds into the reason why, since these patients are asleep and it's not painful to place needles, it's best to place the electrodes as needles so that they are easier to keep in place. And like I said, there's some smaller real estate down there. So making sure that you can get the most optimal responses, and if that means having a bilateral stim and a bilateral recording, that can be your best bet as a backup. And then for posterior spinal surgeries, you can place your stimulating electrodes before the patient's positioned and then place the recording after, so you don't have to worry about anything coming up. And like I said, don't be afraid if you're doing these intraoperatively. Of course, a lot of the papers that's published on all of this has been done in the clinic. So they're using different kinds of surface electrodes. But again, we regularly do use needles in our practice as it makes for easier recording and more secure placement. So BCR protocols and settings. So you have options here. You'll want to use a constant current stimulation, so you really can choose what mode you want to set it up with depending on what kind of equipment you're using. The pictures I have below are set up with motor evoked potential mode just for ease. And I can provide these photos if anyone's interested after the webinar. But your stimulation parameters, 5 to 50 milliamps, pulse count of about 4 to 5. A duration is going to be higher than you typically would use for your posterior tibial nerve or other SSEPs. of 500 microseconds, and then an ISI of 3 milliseconds or 333 hertz, if that is what your machine is set to. A double train stimulation, if you're having trouble getting your responses with those values, is definitely the next step to try. It can definitely enhance the response. But you do have to keep in mind by doing a double train stimulation that you'll need to increase your time base then, and configure the second train identically with the same ISI and stim intensity as you have for your first train. So you can divide your pulse counts up 2 and then 3, and then do an intertrain interval, which can vary, maybe start somewhere between 150 to 200, which is typical, and then you can try varying that from somewhere between 75 to 250 to see if that helps obtain the response. So your recording parameters, very simple, whatever you set your EMG to normally. The display sweep, 200 milliseconds is a typical place to start. However, I would say these can vary based on age and pre-existing pathology greatly. So you have to be prepared to troubleshoot, be prepared to be looking for a later response if you aren't getting or seeing it on your screen. And same with the sensitivity. So you could have an enormous response that's jumping off the page and you need to scroll down, or you could have a response that's so small that you need to increase that. So I have 2 examples here. On the left, you can see this is a pediatric patient, and we have a 100 millisecond sweep on this one, and it's a very large amplitude response. Versus the one on the right, which is an older patient with pre-existing pathology. And so we have a 500 millisecond sweep, much, much longer, and then a lot smaller response. So again, this is all going to be dependent on your patient. The acquisition frequency, this is probably one of the biggest benefits to running the BCR recordings, is that they don't typically interfere with the surgery, and you are able to record them very often. So you can run them almost continuously, especially during risky surgical maneuvers. The great thing is these are monitoring both sensory and motor pathways. So it's a really, really great alternative to switching back and forth between running your motor evoked potentials and your sensory evoked potentials. And you can also set up recurrent stimulation. Let's go through really quick the morphology and components of the waveform. So as was already mentioned, there's both an early and a late response on these. And the R1 response is going to fall usually somewhere around 30 to 35 milliseconds in adults. However, that last slide I showed you, that patient's early response came in, actually, I think it was closer to 80 or 90 milliseconds. The R1 response does not habituate. So constant stimulation is not going to decrease the size of this response. I think I saw that pop up, somebody asking if your pudendal SSCP stimulation would affect your ability to collect a BCR response. It is the shortest pathway response, obviously, it comes in first, and it's oligosynaptic, which means it's interrupted only by a few synaptic junctions. So more than one, but less than poly. And the R2, the late response, is polysynaptic. So you're going to see that more affected by your anesthesia and might be a little bit harder to collect a good response from in the OR. The number of neurons fired is going to correlate roughly to the complexity of the BCR response. So some things to keep in mind for troubleshooting: if you're getting blunted signals, you might need to use longer length needles for recording from the anal sphincter. If you're having a significant stimulus artifact, some things you can do to remedy that would be to increase your dynamic range, switch to biphasic stimulation. You can move your anode and your cathode closer together. And if you're using surface electrodes, make sure you've really prepped your stimulation site well prior to placing the electrodes. Or like I mentioned, alternatively, use needles instead of adhesives. If you're just getting no response at all and it's just completely flat, you definitely want to check your stimulating electrodes for connectivity. And again, another reason why it's great to do that bilateral stimulation, so that you have two options to use for your stimulation. Great for troubleshooting. Increase the intensity would be the first step. Maybe it's just taking a little bit more to get those to depolarize. And then the last step would be to switch to the double train stimulus. So some troubleshooting tactics for unique patients. Patients with neuropathy at the conus are going to probably require higher levels of current and longer duration of stimuli. So you might increase those. Patients with upper motor neuron disease might experience what's called a disinhibited BCR, or anticipated released response. So these patients are going to have a really low stimulation requirement, not a high intensity to evoke a response, and there might be also a prolonged discharge. Pediatric patients, another great paper by Huang in 2017, recommends for infants less than 24 months that you use a biphasic 8 pulse count stimulation with 2 millisecond intervals. It's just something to keep in your tool bag if you're working on some of the younger population. So alert criteria, of course, disappearance, complete disappearance, especially when it's linked to a risky surgical context. And then how we were talking about the number of neurons fired correlates with the complexity of the waveform. If your waveform starts diminishing in complexity, as in the duration or the turn count, this could be a forewarning that a disappearance is imminent, or it could indicate that there's an incomplete degree of conduction block. So there could be something in the system that's blocking the signal from getting through, but not completely. So it's an opportunity to bring this up, to discuss and figure out if there's anything that can be done to prevent a disappearance and to allow the response to return. So there are a few disadvantages to running BCRs. The gas and muscle relaxants are absolute contraindications, which makes it difficult if you are working with an anesthetic team that is not super into helping you obtain the best responses. And they also require a high level of skill for correct setup and troubleshooting. There are far more advantages that outweigh the disadvantages for this modality. It can be run continuously and often. It doesn't cause a lot of patient movement, so it's fantastic as far as being able to run it constantly. It doesn't require any averaging to be done. And it's an evoked potential, and it can detect stretch injury, which is superior to just running spontaneous EMG. It has a very specific target, right? So we're not going all the way up to the brain like we are with our motor evoked potentials and somatosensory 3 evoked potentials. So if you're interested in monitoring the sacral system, very specific target. And it simultaneously monitors both sensory and motor components peripherally and at the segmental level. So fantastic modality. It's very robust and reliable, and it can be tested often, the 3 most important criteria. So let's revisit the poll. Do you feel comfortable explaining to someone what information
I found this on the web.
A reflex response gives? And just a couple of my favorite quotes from some papers on this that just go over the anatomy and what information this response does give us. Oh, it's not letting me. Oh, there we go. And one of my favorites, how to describe a BCR alert. Conduction block has developed within 1 or more constituents of the somatic low sacral reflex arc. And if you're wondering what, again, if my webinar is going too fast for you and not sure what the somatic low sacral reflex arc is, the 2 quotes above give a really great, great description of what that encompasses. So pudendal SSEPs, true or false? If you are monitoring posterior tibial nerve SSEPs and bulbar cavernosus reflex responses, there is no additional patient setup to monitor pudendal SSEPs. Go ahead and send in your responses. And we'll start doing a little review of the pathway. So the components, stimulation, follows the nerve, up the nerve roots, through the spinal cord, and recording from sensory cortex. As was already mentioned in the previous webinar or previous presentation, the best recording site found by Haldeman was CPZ, and the medial aspect of the cortex deep in the interhemispheric fissure is actually where the sensory components for these lie. So that is why that is the closest location we can actually get, as you can see from the picture. So anesthetic considerations, really the same as you would for any SSEP. The supplies, you could use a 7 to 13 millimeter paired needle electrodes or the surface electrodes for stimulating. And then of course your head leads for recording. So let's revisit the poll. This is a true statement. If you're running your posterior tibial nerve SSCPs and your BCRs, there's nothing else that you need to set up as far as the patient goes. So same stimulation as BCR, same recording as your PTNs from CPZ to FPZ. And here's the picture from Haldeman. You can see the CPZ recording is just much more robust of a response. So protocols and settings, the main difference you're going to see with this is just to start your pulse width a little bit lower than you would, but you might need to increase that back up. And then your recording parameters, also whatever you would normally set your posterior tibial SSCPs to. And same for the display. You can use a sweep of 100 milliseconds or more. And a sensitivity, it might be a little bit smaller response. You might need to increase the size a little bit. Unfortunately, it does take time to average, just like your typical SSEP. So the acquisition frequency is not going to be as often as for your BCR, and you can run intermittently rotating through other tests. So the waveform clinically presents in this W shape with 4 points, P1, N1, P2, and N2. And intraoperatively, as was mentioned, very similar in context to the posterior tibial nerve. One of the questions that we saw was asked was about pudendal neuropathy. Don't really have time to touch on this much, but there's a couple good papers on this. These are clinical papers that use patients' positioning to describe different sorts of entrapment that can happen. And it's important to note that the pudendal nerve splits into 3 peripheral nerves: inferior anal, perineal, and dorsal nerve, which is the one we're stimulating. So for example, if there were to be entrapment in Alcock's canal, which the dorsal nerve does not travel through, stimulation of the dorsal nerve could miss that entrapment. And this is another paper where a perineal nerve SSEP was elicited. All right, and then external urethral sphincter, EMG, and motor evoked potentials. Do you feel that adding this monitoring to your current setup would be technically challenging? Quick review. I think Faisal covered this fantastically, so I'm going to skip through it so we have time to get to 2 case studies. Anesthetics, same exact scenario as you do for your limb evoked potentials. The supplies, it's a catheter with gold electrodes that comes in varying sizes. I prefer to use that link quadrupolar motor stimulation for my motor evoked potentials, just to get a good variety of stimulation sites. And we do use the corkscrew electrodes for a larger surface area of stimulation. So let's revisit the poll. Do you feel that adding the sphincter monitoring would be technically challenging? Well, the nurse is coming to your rescue. So she's the one who will place the Foley catheter in the patient. So for you, no, not really. Although if you have a difficulty of not having the correct size for the patient, then that is where things can get hairy. So as was mentioned previously, making sure that you know what size is needed by your surgical team for that particular patient is going to be the most technically challenging part of the setup for you. Just some pictures, beautiful, beautiful model made for me by Brett. A little bit wonky looking because I've inflated this balloon so many times to show our interns, but just the way that the electrode sits in the bladder and is used to record. And the the recording site is nice and long because the location of the external urethral sphincter on females versus males is different. So you don't need to get a different type of catheter for males versus females. All of these catheters will work for either sex. The most important thing is just to know what size you need. So here's just kind of our troubleshooting algorithm that we use for stimulation of our lower motor evoked potentials, but really it's going to be the same recording and stimulation parameters that you would use for your motor evoked potentials and EMG of the lower extremities. So I got just some different pictures that kind of show you the different morphologies that you might see in patients of the urinary sphincter and the anal sphincter in surgery. And one of the other questions that came up was, what's the approximate, let's see, the approximate latency. So I would say on average, it's going to come in before 30 milliseconds. And again, this can really vary from patient to patient, but you can see from these pictures, it is typically going to be coming in very, very close in line with the anal sphincter. And the response can vary pretty distinctly. So in these ones, it's looking a little bit more blunted, again, than some of the other ones that are a little bit more crisp. And sometimes the response is, like in this scenario, a little bit small. Sometimes it's very robust. So case study number 1, we're going to have to go through this pretty quick, but have you ever monitored the pelvic floor in any fashion for an intramedullary spinal cord tumor at the conus? All right, so we have an example case. T10 to L2, 75-year-old male. He had progressive lower extremity weakness, pain, bowel and bladder control issues, and primary tumors of the spinal cord, which you can see in the scans to the left. We did Ativa anesthesia, kept the map up, and no muscle relaxant was on board by monitoring start. The two modalities we're going to focus in on for this are the BCR and the urethral sphincter TEMG that were critical in the development of this case. So here's the setup. We did the urethral sphincter recordings, and then the setup right in that infrapubic location with the double stimulation for our best chance of obtaining reliable signals. We also did place the surface electrodes on the dorsum of the penis as a backup. So really had 3 stimulation sites and used lots and lots of tape, as you can see. And here is the Foley catheter coming out. Here is our baseline data, nice, beautiful, robust responses from the bulbocavernosus reflex. And our motor evoked potentials had a little bit more difficulty obtaining the responses from the anal sphincter and the urethral sphincter. So we were grateful to have a BCR response. After the surgeon got down to the level of the conus and opened the dura, we went ahead and stimulated. And at multiple times, we got responses from the urethral sphincter and from the anal sphincter, and not from any other parts, muscles that were being monitored. So it was really crucial that we had these electrodes in place to be able to identify these systems that were not being monitored by the lower extremities. So sometimes we get responses from the foot or the gastroc or other muscles. And at one point, then we started getting some significant spontaneous EMG activity during all the manipulation. So we ran our BCR and saw that it was lost. So the surgeon took a surgical pause, removed everything from the field, and we continued to collect BCR continuously, as we mentioned, they do not habituate with stimulation. And 9 minutes later, the right side returned and the surgeon resumed the surgery. We did some more triggered EMG mapping, and he was able to take a limited biopsy and resect small fragments to send to pathology. But the mapping was critical. was critical to letting him know, because what he would have taken a large chunk of thinking it was tumor actually turned out to be parts of the conus. And at this point, we had, again, on the left, another loss of the BCR. The surgeon did the same thing. He took a surgical pause, and this time it returned within 3 minutes. In conclusion, the patient's bowel and bladder function was preserved, and they were actually discharged to rehab 2 days after. The surgical pauses with the loss of the BCR, we believe, could have aided in preventing dysfunction. And triggered EMG mapping of both urethral and anal sphincter helped him avoid removing any motor structures. So some critical lessons: don't rotate through other tests during critical parts. Keep running the BCR continuously. If it disappears during dissection, the surgeon should stop. Laser and cautery can send discharges that heat the cord. And a tight suture can also place a lot of pressure on the contents of the conus. So that can potentially be another cause after the fact. Important to always be recording the context and staying in good communication with the surgical team so that you can report context-driven events. And remember that pudendal neurons are built to fire, so they don't habituate from activating them too often as other systems do, so check continuously. It's also possible to see a BCR change with a stable anal sphincter or urethral sphincter motor evoked potential. The approach for this procedure is posterior towards the afferent part of the cord and the afferent nerve roots. So only measuring efferent pathways, you could miss information. So that's another reason why it's so helpful. The pudendal SZPs in this case weren't obtained. They can be tricky to obtain. And I think we're going to just kind of cut this one a little bit short since we're running out of time, but what's the youngest patient you think should be monitored for pelvic floor function intraoperatively? All right. So according to the National Institute of Diabetes and Digestive and Kidney Diseases, by 5 years of age, over 90% of children have daytime bladder control. However, right, just because the patient has control of their bladder before that age doesn't mean that they don't still have function, even if they don't know how to use that function, right? So ideally, we want to be able to monitor them as young as possible. And motor evoked potential recordings have been published in a baby at 15 days of life. This isn't pelvic floor, but just from the limbs. I'm going to show you guys some pictures of pelvic floor monitoring in a 6-month-old patient that I recorded. Beautiful BCR responses. Gorgeous triggered EMG urethral sphincter responses from this patient using the smallest catheter size. So this part becomes dependent on if it's able to be placed, if the electrode is able to be placed. But we were able to adequately monitor this patient for a tethered cord release, the 6-month-old patient, and get beautiful pelvic floor responses. And we're just going to go ahead and skip through this one, but this is a 6-year-old patient. Get to the end. And again, had beautiful motor evoked potential responses, great anal sphincter responses, reliable BCR responses. And they were able to isolate the phylum, test it 360 degrees around, keep running BCR during the untethering, just in case there was anything we were missing during the triggered EMG. And when the phylum was released, everything stayed stable as far as our motor evoked potentials and our bulbocavernosus reflex. So in conclusion, you should add your pelvic floor monitoring to your practice. The tools are very powerful, and there's a great availability of modalities to be run.
Thank you, Katie and Faisal, for very nice presentations. There's so much to talk about. We do have many questions that have been submitted, and some have been answered. In the sake of keeping everyone on the same page, perhaps we should take one question at a time and and go over it. One of our let's just take this from Dr. Pace, Chris Pace. Um, do you find that running pudendal SSEPs impacts your ability to evoke BCR? And Katie, you alluded to this. Faisal or Katie, would you like to address this to touch?
Um, Thank you. That's a nice question. Very good question. The only thing is when we are running the BCR and pudendal SSEP, so we are doing intermittently. So they are not going to affect each other. The one thing that can come up from this question is we have tried and recorded pudendal SSEP from recording the bladder electrode. So pudendal SSEP can be done as presented in the second lecture, that by placement of the surface electrode or needle electrode in the genital area, but you can also try using the bladder electrode. You can stimulate the pudendal nerve and record for them. The success of that is not as high right now because it's just a new thing and we are still trying and collecting the data. One thing we are trying to see is the difference between stimulating bipolarly inside the bladder comparing to using one electrode on the bladder electrode and one on external electrode.
Katie, did you have anything, because you had mentioned this in your...
I think just, you know, you obviously can't run them at the same time, or should not run them at the same time, but I think, you know, as mentioned, that the BCR responses, the pudendal motor neurons are built to fire, and so you don't have to worry if that's the concern about a habituation of the signal from overstimulation.
Okay, so next question. I see John Paul Sumaquero, always nice to see you, asks, literature is not consistent with running MEPs on tethered cord. Most lit suggest that triggered EMG and spontaneous EMG are sufficient. How would you educate a surgeon? How do you go about talking to your surgeons on the utility of adding MEPs to the procedure? Dr. Sala and his group advocate running MEPs, but Newer's text doesn't. Thoughts?
So running the MEP is again controversial for tethered cord. So we still have both sides of the authors, like they're saying just triggered EMG is enough and MEP. But one thing that we are trying to add here is most of the patients, a big number of patients in these cases, they can wake up with a urogenic bladder. So when we are running MEP, when you're talking about these papers, they are talking about the muscle MEP from the lower extremity or anal sphincter. So if you're doing MEP from anal sphincter, then you can focus primarily on pudendal nerve. But the higher risk is the urogenic bladder. So if you have a patient where it's not a simple tethered cord, it has a meningeal or myomeningeal or any extra tumor, and you have a risk of having a urogenic bladder post-operatively, then the only way you can prevent that, not 100%, but you can add another modality, is using MEP from the bladder muscle, external urinary sphincter muscles. And we can do MEP and trigger EMG for identification and MEP for continuously running to make sure the pathway is intact.
Katie, no.
I think that's great.
Okay, so the next question I think has been discussed a good bit here. Would it be possible to do BCR and external urinary sphincter as well? And I think that has been answered. Anything you would like to add?
Yeah, again, the BCR, so you can use the same bladder electrode. So you can do BCR by surface electrode, as Catherine said that, but you have two options now. You can do the surface BCR and you can use the bladder BCR because it's the last few years we are doing that. So the data is still not enough. So once we have enough data, we have like hundreds of cases, then we can publish that data. But so the main, one of the purpose of this presentation is not to give you a decisive answer or decisive material, but it is inciting a seed for the thought. So you start going back and think that there's something else you can do in these surgeries. And you are well, and I'm challenging you, and I'm inviting everyone to collect the data and publish the data, and hopefully we can combine the data and have a very good outcome. So one thing you can do is do your own testing, run BCR from the internal electrode and surface electrode and see the comparison. So you can do BCR and put analysis B from surface and internal electrodes.
Which it makes me think of another question that my friend Dr. Wierzbowski has asked.
Yeah.
He asks, since pelvic floor anatomy and neurophysiology have many unknowns, have either of you tried recording from the external urinary sphincter with urethral catheter electrodes to BCR stimulation? And Faisal, you had answered this question, but
Yeah.
I would love to hear a little bit more about it.
Yeah, thank you, Larry. So the reason we haven't tried that, the reason because your BCR stimulation and external urinary sphincter are they're so close. So the only thing is we have done is we have tried to stimulating from external urinary sphincter and recording from the internal anal sphincter muscles.
Be
So
very.
yes.
So you have tried, or?
So we have tried. The success is not very high, but we have tried. So because every patient is different, so we are not still. Every time we are trying, we have a different patient, different pathology, and different catheter side. So it's very hard to have one catheter size and comparing to the other catheter side. But we have tried comparing the stimulation from the external urinary sphincter and surface electrode, doing the BCR and recording from internal anal sphincter. And there's a possibility. So it's not a zero.
I hope everyone forgive me for throwing in a question that I have had that did come up a couple of times. When we look at the innervation of the entire pelvic floor, including the rhabdosphincters, whether it's the anal sphincter or the urethral sphincter, everything is fired in synchrony, whether it's somatic, whether it is parasympathetic, whether it is sympathetic. Everything has to fire physiologically in synchrony. And so much of the other neuromonitoring that we do is asynchronous. And the limbs they fire so independently. I have always assumed that a given sphincter muscle, or even some of the pelvic floor musculature, if you fire one side, it tends to cause the other side to fire, say the anal sphincter, the external anal sphincter. But I don't know. Some of your data shows a response on one side or the other for the anal sphincter. And have you guys thought about what synchrony does to our neuromonitoring of the pelvic floor? I really don't have a clue.
That's some very good questions, because in the pelvic floor it's very different from the regular neuromonitoring we are doing for SSAP or MEP, because now we have sympathetic plexus and parasympathetic plexus. The sympathetic plexus originate from the lumbar roots, so it's T1 to L2, but parasympathetic has origin from brainstem and from sacral roots. So if you're doing transcranial stimulation, you are activating the brainstem, which is actually not controlling the pelvic muscle. They are going to the more cranial side, but it's activation of all the both sides bilaterally. And as Brett, you said, in order to activate the parasympathetic system, the sympathetic has to relax. So you cannot have because even we are stimulating both at the same time, or we are stimulating nerves which have sympathetic, parasympathetic, and stimulating both at the same time, but both have to activate in antagonist way. So if the sympathetic is not relaxing and parasympathetic is not activating, it's not going to work. But there's so much data, there's so much different things. So at a micro level, we have to do, we are very far away from that point.
I want to encourage the audience, keep, if any of this brings more questions, please feel free to keep the questions coming. Here was a question that after an ovaric surgery, I developed overactive bladder. Is there a way of monitoring the detrusor muscle? I had no symptoms of neurogenic bladder before. And this is something that comes up constantly when we think about our neuromonitoring. Smooth muscle. And it is, I have been asked a question before of how are you sure that you're monitoring somatic when you're, let's say, from the urethral, because it is surrounded by smooth muscle. So is there a way of monitoring the detrusor, the smooth muscle?
So there are multiple papers published, mostly from Germany, and they are the way for monitoring those muscle intraoperatively is using a pressure electrode. So the same bladder electrode, you have a pressure measure, so you are monitoring actually so one of the slide, if you go back once you're reviewing the slide from one of the presentation, monitoring of pressure manometry during the surgery as well as EMG. So right in US, we don't have that intraoperatively measurement, so it's mostly clinical measurement, but we can do that. So intraoperatively, it's a possibility, and it's being used right now in different countries using a pressure monitor, which is direct measurement of the detrusor muscle.
So that correlates well with detrusor activity, just a linear relationship between pressure, and that's assumed to just indicate detrusor activity.
Correct.
Okay. There is, oh wow, here is the urethral electrodes are homemade or available on the market. They're not homemade, they're available on the market. Let me see. Do you have experience with cervical spine surgery? Or TCMEP from external urinary sphincter modified in a significant way during surgery? Do you have experience with cervical spine surgery? Are TCMEP from external urinary sphincter modified in a significant way during surgery? I'm not sure what that question is asking. Do you guys have any thoughts?
So if you're talking about monitoring of the bladder during the cervical spine surgery, so we haven't done yet. The highest level we have done is L5S1, so not gone.
Yeah. Next question. It always must be must have MEP from external anal sphincter and bladder, or have external anal sphincter can predict injury. It's always must have MEP from external anal sphincter and bladder, or have external anal sphincter can predict injury.
So that's a very good question, and that's one of the basis of this presentation, having multimodality, because until now we were recording MEP from anal sphincter and assuming the pudendal nerve is fine. But the pudendal nerve is not going only to the external anal sphincter. Pudendal nerve has motor fibers, it has sensory fibers, has sympathetic and parasympathetic all input. So if you still have intact anal sphincter muscles, external anal sphincter, patient can still wake up with a neurogenic bladder. So, and the surgeries, especially the studies I was reviewing the literature, the abdominal perineal resection surgeries, they have a 50% chances of a post-operative urogenic bladder. The low anterior resection, LAR, or mesorectal colon surgery resection, they have about 15 to 25% risk of urogenic bladder. So if you add external urinary sphincter, you are monitoring the roots of the pudendal nerve, which are going to the bladder, as well the roots going to the external anal sphincter. So those terminal roots are affected, which is most likely in those pelvic surgeries, you can identify separately. But if you're monitoring a spine surgeries or tethered cord, very quad equina, then both will be it's very difficult to have one affected but not the other because you are more proximal to the terminal branches. So they are independent of each other in the pelvic floor surgeries, but at quasi or high level, they are more synchronous.
Here's a interesting question, because BCR responses are sometimes unstable, appear and disappear. Adding pudendal, and I assume that that's talking about the perineal evoked responses and external anal sphincter in the same procedure would be mandatory, right? It is my experience, and this is from Dr. Santiago Sanz. Is that your experience?
So we cannot say mandatory because you are stuck in catch-22. If you say mandatory or have mandatory, then if somebody is not doing that, then you are stuck. So until we have enough people who are certified or trained to do every single case and do both activity, you cannot mandate that. So we are stuck between catch-22. So we cannot cause mandatory until we have trained people, and we cannot have trained people. So anyway, so it's always recommended to do both of them, and it will take a while to train people and have enough people to do. Otherwise, you have to cancel the case and until somebody shows up with experience.
So here's an interesting question, Katie. It'll be I'm sure you're going to have a thought on this. Do you think it is Javier Gonzalez asked this question? Do you think it is possible to monitor BCR for 1-week-old baby in a surgery for neural tube defect correction? Very interesting question.
I haven't done it. I think it's worth a shot. Faisal, what do you think?
So I have to go back, but I don't know how youngest, but you can do the BCR on 1 month, but you have to use the surface needle electrodes for that.
And this was 1 week old.
1 week? Oh, okay. I thought 1 month. Oh, I'm sorry.
Yeah, it's
1 week.
I'm sorry. Perhaps
okay.
I read it wrong.
Yeah.
It's asking for a 1 week old.
7 days old.
Yeah, I have never tried on 1 week BCR, so I'm not going to just say anything.
Yeah, I think like what's important too is, you know, what Faisal was saying about, right, like we don't have all the answers. None of us have all the answers, and it's up to all of us in the field to start working on finding answers and looking for to make use of those opportunities, I guess.
Okay, next question. Can the needles damage any blood vessels of penis?
So I think where I've been placing them for the bilateral stim, and I think I'll pull this pictures way back here, is not actually on the penis itself, but above it. Let's find. Wow, it's way back here. Sorry, guys.
So you have to stimulate, you use the surface electrode if you're using the dorsal surface of the penis.
Yeah.
But if you're using on the base of the penis, then you can use needle and.
Oh, I went too far now. Yeah, so the location that I've now been finding preferable. So this would be with your surface electrodes. Oh, it's right here. And you just place the needles right there.
Okay, so let me get back. Got a lot of windows going on. John Umina, have you noticed scenarios where the catheter has produced EMG or TCMEP traces while a conventional pair of external anal sphincter electrodes have not? I assume that he is talking about needles. Have you noticed scenarios where the catheter has produced EMG or TCMEP responses while conventional needles anal sphincter have not?
So the two paper we published, they are available online, and so we have much higher. So with EMG, we had 100% success rate with the catheter, and on those patients, the anal sphincter was less than 80%. For MEP, where success rate was we had 79%, 83%, as compared to TCM from anal sphincter, which was less than this. So the success rate for both EMG, trigger EMG, and MEP was much higher as on the bladder for our study comparing to external anal sphincter, and they were more robust responses.
So is the question asking, is it possible, like for triggered EMG, to get a response isolated to just the urethral sphincter or just the anal sphincter?
I think that's the question.
And
yes.
I think I'm, you know, again, we're all still learning. I think that it's possible, and it's not common though. So I've, like you can see in this, you know, pretty large responses from the urinary sphincter, maybe just a small left anal sphincter response. And then I had another one as well. I was trying to see if I could find any where this scenario occurred, where there were responses. So at this location of stimulation, there was responses from the anal sphincter, but not from the urinary sphincter. And then another spot where there were responses from both.
I've got a question based off of this, and I think I know the answer, but I'm interested in your take. There's spatial separation in Onuf's nucleus for the neurons related to the external urinary sphincter and those related to the external anal sphincter. They're spatially separated in Onuf's nucleus a little bit. Do you think that the differentiation that you're seeing is coming from the different pathways, that the rootlets that enter, that the fibers that ultimately go the perineal pathway to, say, the external urinary sphincter? Do you think that the differentiation comes more from the anatomical route that those pathways are going, or is it possibly due to some of the differentiation in Onuf's nucleus?
There's a definitely possibility, because Onuf's nucleus is doing is just focused on the parasympathetic pathway, but the sympathetic pathway is coming from a different, from the fiber outside the
I thought that wasn't Onuf's nucleus also the somatic, related to the somatic? Maybe I was wrong.
I'll double check,
Um,
but
well, the next question from Dr. Martinez. I am doing intraoperative monitoring during Da Vinci TME. Not sure what TME is. Do you think BCR monitoring is useful during this kind of case?
So TME, total mesorectal resection for the colorectal surgery. So if you're doing, again, for these TME surgeries, urogenic bladder has a very high postoperative, you have a risk of urogenic bladder. So having a BCR monitoring will give you the pudendal nerve reflex. So just doing the regular triggered EMG during this procedure, which is typical people are doing, cannot give you 100% coverage. So having a BCR monitoring can add all the pathway which are involved in that, which include the sensory, motor, and others. So it's going to be like additional. And once you have a changes in both of them, then there are more specific changes. So the sensitivity is much higher with change in BCR and the direct stimulation.
We are coming to the end of our time. In fact, right now we're at an hour and 40 minutes. Why don't we extend for 10 more minutes for anyone who can stay on? But it's important for everyone who is out there to know, at the conclusion of this, we have a recording. It is going to be posted on YouTube where everyone can see the complete recording. And we will be emailing out a link to everyone who is here and who registered, in fact, to view that recording. So if you need to go, thank you for attending. We are going to stay on because there seem to be more questions coming in. We're going to give it just 10 more minutes, and then we will conclude. And now I'm a little bit lost here as far as all of the new questions. What do you think about monitoring bladder pressure and its use in surgeries like selective dorsal rhizotomy? I know you've discussed that a little bit, but you want to talk about that more?
So you can use the bladder electrode pressure monitoring, but when you're doing selected dorsal root rhizotomy, we intentionally spare the sacral roots. We don't cut S2, S3, S4 roots. So if you're doing rhizotomy, you are going to do split the nerve roots from L1 to S1. But once if you stimulate the nerve and you identify the nerve is S2 or S3, we are not going to do rhizotomy because there's a more risk of damage than that. So typically it's not done. So having a bladder pressure may not give an additional benefit for these cases, but having you adding an EMG for that trigger EMG will maybe benefit, because if for some reason you cannot identify the roots from the anal sphincter, you can have a backup electrode from the urinary sphincter, so you can have a trigger EMG. So for again, for SDR cases, rhizotomy, so for a trigger EMG may be more beneficial than doing the bladder pressure for those surgeries.
Here's an interesting discussion, and it brings up an interesting question. Monica, forgive me, but the last name is Belmonte, says, we are currently working on characterizing surface EMG recordings of pelvic floor muscles, but neurological activity can be of great interest too. So this brings up a question that is constantly on my mind, is morphology, density, number of turns, just in general, the robustness of the EMG activity that we get. To what extent do you guys get information from just how strong the responses are? Or I think the answer is you're just looking for gross activity. If you see a compound burst, you're happy. Is that correct? From your
Yes.
EMG?
Yeah, right now we have not analyzed. Again, we need to analyze. So right now we are happy with compound muscle action potential, and we have most of the time it's polyphasic, multiphasic response. So the next step we can do that we can analyze is collect the data and do the area under the curve. So how much activity and also reference that to the intensity of stimulation, the nerve roots. So even so S2, S3, S4, S1, they are going to give, everyone is going to give you a different threshold. So if you're stimulating, so it's not a very consistent stimulation, because S3 has the most contribution to the bladder, but S2 has contribution, and S4 and someone. So you need to, we still have not correlated the data, the amplitude of the response and the morphology and the area recovered to the intensity of the stimulation, and of course pulse width and everything.
And you know what, Faisal, as you're talking, it is so hard to try to do any assessment on morphology simply because of it's like some of the work you were showing on the deeper needles. You know, the closer you are to the source, that you get higher frequency activity. And because of the quadrupole nature of EMG, you're going to quickly attenuate to high frequencies. Say if you're using a surface electrode, you're going to have tremendously attenuated to high frequencies, although you might get those nice slow waves of EMG. It all depends on the electrodes, doesn't it?
Yeah, well said, Brett. So closer you get,
Well
you're,
said.
you get much higher frequency and much better amplitude, and you are recording in multiple dipoles. You're not on one dipole. So more far you get more. You get on a dipole. So you get closer, you get a quadrupole or maybe more. And the second thing is you lose the stimulation artifact. So what we're seeing with the surface electrode, we have a huge stimulation artifact because of the stray current spreading over the skin. But comparing to the deep electrode, we have minimal to no stimulation artifact.
Right. Forgive me, guys. I'm a poor moderator. I am lost as I'm looking at the questions, and I'm confused as far as the ones that I have brought to the presenters and the ones I haven't. But let me go back because I think there were some in the beginning that I missed. Are there? Here was one. Are there any study for autonomic part of pudendal nerve? And Faisal had already said, yes, there are paper published monitoring autonomic system. And you talked about the autonomic system. Do you have anything to add about the autonomic aspect?
So again, so the autonomic nervous system is supplying your bladder electrode, sorry, bladder muscles, your rectal muscles, and the prostate. So those are the three organs in the lower pelvis, which is supplied mainly by the autonomic nervous system. So we can do those. We do those monitoring when you're doing trigger EMG for sympathetic or parasympathetic plexus or autonomic nervous system. We are activating those muscle fibers in sphincters, bladder sphincter, sphincter, and nerves going to the prostate. So, so, so the whole monitoring intra pelvic area is covering the autonomic nervous system. And also forgot to mention is the bladder pressure. So having a bladder pressure heading, that's all. So the autonomic nervous system can be monitored, and it's being monitored.
Here was one, and you had already answered this, Faisal, but it is an interesting question. Dr. Tello, Armando Tello, who is a frequent presenter, he asked, from where do you start to measure MEP latencies? From time 0 or from the 1/3 of the start of the TCMEP stimulation? And Faisal, you had answered from 0, but this brings up an important question. Yeah. Do you guys really look at anything other than just a gross indication of latency? I mean, is it worthwhile?
So what we are looking at beside the latency, you're just talking about latency, or so we are looking at latency, and we are looking for morphology and morphology of the waveform. Is it it's a multi-phase, they have 3 peaks or 4 peaks or 5 peaks, how many peaks, and how much is changing throughout the surgical procedure. So that's, but right now, the problem is like if you start measuring the latency from the 1/3 or in the middle after 0, and during the surgery you have to change your stimulation parameters. Sometimes you're getting very good response at 4 train, and then you have to change to 5 trains. And if you start from last train, then the latency will change. We also do double train. So in the middle of case, you have changes, you do double train, and you double train, then so the interpretation goes off the roof. So until we get like a very good some studies that tell the difference that can compare the difference between the two, so it's much easier for people who are getting into the field, or they're trying to start recording, is to start with a 0, because then all those other factors plays in easily.
And I think it's important to pay attention to the latency of the other muscles, right? So it's all patient dependent. And like Faisal's saying, if you're changing your ISI or you're changing to double train in the middle of the surgery, you know, it's going to completely change the latency on the screen. And so I think it's important to kind of know what's the comparison between your foot muscle and your hand muscle and your urethral sphincter response, where do they fall in time comparatively to each other?
Yeah, that visual of, am I looking at the right thing compared when I look at everything else? Right.
Yes.
Okay, so last question, because we really do need to stop. We're a little over time here, and this is, Katie, this is something that I thought about during your presentation. This is it better to shave the site prior to placing electrodes and tape? Because ouch. And also, what is the reliability of tape? I wondered that. I mean, you can see that in some instances you had to shave. And what about like Tegaderm? What are your tape options what's everything you've tried?
So I definitely think if it's extremely hairy and you have a razor available, it's definitely not a bad idea to go ahead and do. I haven't had, while using needles, I really haven't had a lot of issue. And I think it's partly just from having set up so many patients, you kind of get a technique. And for me, I know what works well is when you place it in, just kind of having that extra little bit of lead of the wire that when you tape it down, it's kind of smushed up a little bit with itself, for lack of a better way to explain it, and stress loops. So that way if it gets yanked or pulled or such, that there's a certain amount of it that can be yanked and pulled without the electrode coming free. I'm partial to the silk tape. I don't think, I do use like Tegaderm and stuff like that on the face and the head. I don't think it's necessary down there, but if you find that it sticks better for you, it kind of is, it's going to be individualized. Like, what do you find kind of works for you? For me, I love the silk tape. I think it works really well, and I don't usually have a lot of sensitivity. That's another concern, right? Is like the sensitivity of the patient's skin to tape, especially if it's a lengthy procedure. But for like example, the anal sphincter electrodes, again, just you're using those longer electrodes, it helps them stay a little bit more secure and in place. And I don't put any tape at all on the actual sphincter, but I make a nice stress loop, and then I tape down behind that, and then I typically fold and tape down the stress loop. So then it kind of allows that electrode to be in place more securely.
Right. I wonder how many technologists, back when I was working as technologist, I constantly had silk tape all over me, ready to go. Silk tape is our friend,
Yeah.
for sure.
Yeah.
I'm a Tegaderm guy, so
Tegaderm guy.
Tegaderm, because with the Tegaderm, it's always more secure than silk tape, and you can see that electrode. So that's another benefit. You can see
That's
you
true.
don't have to do it's a command, but it's like your choice, personal choice. So.
Yeah.
Well, we thank you. I see comments coming in thanking both of you, and I want to mirror that. We really appreciate phenomenal presentations. A note to the audience, you will be receiving an email. Please feel free to reach out to us for any questions, and hopefully the video, it's there. It's for you to view again, and we certainly appreciate your time. Oh yes, we will be mailing out a certificate, and there will be 1.5 CMEs given for this. So those will go out to everyone. So I think that I'm supposed to just say we're done and we can all leave. So Mateo, if I'm supposed to do something different, please just text me here. But we certainly appreciate your time, and I'm being told we can close. So thank you, everyone, and especially big thanks to Katie and Faisal. Bye-bye.
Thank you, Brett.
Thank
Thanks
you.
for hosting.
Thank you, Brett. Thank you, everyone, for attending this.
Yep.
Bye-bye.
Bye.
Bye.